tying in course content looking at patient-physician relations, there are models to describe the way a patient can go through euthanasia. Firstly, something called conscious-based refusal allows the doctor to refuse the treatment or medication that a patient may want. This would fit into the paternalistic model, where the doctor believes that they are always in the right, even if they do not have the patient's best interest at heart. This would limit the patient's autonomy and not allow them to make their own decision to continue with medically assisted dying, thus going against many ethical theories as we've discussed prior. The paternalistic model has been the norm for much of medical history. It is in today's day and age that we must look at how this model has many downsides for the patient. As discussed previously, autonomy is a very important part of medical care today, and therefore the paternalistic model may not always be the best way to go in terms of directing the patient to the best form of care.
The ethical theories that we have been discussing have usually surrounded the autonomy that a patient may have when it comes to euthanasia. Having a patient make their own medical decision when it comes to their life fits the engineering model, which was discussed in class. The engineering model is a neutral and objective model that discusses the patient-physician relationship. This model gives a final decision to the patient, therefore allowing for more autonomy for the patient. The physician's role is to present the facts to the patient and ultimately let the patient make the final decisions on their health. The model is criticized because it allows too much power to the patient, and this is problematic because patients may not know what's best course of action for their particular case.
We will now explore the complex ethical and moral dimensions of euthanasia from a nursing perspective, focusing on the challenges Canadian nurses face in end-of-life care. A common saying is that doctors cure and nurses care, so they have a lot of emotional weight when it comes to euthanasia and assisted dying. In the international community of nurses, many say that this process of assisting in someone's peaceful death is rewarding, thus supporting the process of euthanasia. And new studies show that Canadian nurses are also experiencing these satisfying results. Once again, the okaying of assisted death allows for full patient autonomy, which is ethically moral and correct.
Nurses may also hold many ethical concerns against euthanasia. One of the reasons being nurses are the most common caretakers of ill patients in hospitals. This can give rise to many ethical concerns as nurses may feel it goes against their duty to provide care and support to their patients. Moral residue for nurses who have objections to assisted death practices can also be an issue, as in Canada, health region policies may require nurses to take part in euthanasia practices regardless of their beliefs. And moral residue is defined as long-standing feelings of guilt, remorse, or inadequacy in an individual experiences because of unresolved ethical conflicts. This also relates to moral agency, where nurses believe they have no say in the system and that their voice is not heard. This can make it difficult for a nurse to get approval for a patient's request for euthanasia, which could result in more suffering and pain in the patient.
From a psychiatric point of view, a person's life can be very difficult, especially those who have gone through multiple health concerns. A study shows that after cancer, psychiatric and neurological conditions are the most common driving factor for patients to request PAD. This is the case in most countries like Switzerland, Belgium, and the USA. Dementia specifically makes euthanasia a very difficult ethical and legal problem. Because of their brain not allowing them to retain memory, they may not be able to make an informed decision. And patients with dementia are often put into total institutions, meaning they are not able to consent in the same way a normal functioning person can. In this case, it is difficult to understand if they are experiencing unbearable pain, and therefore the patient might not be able to be eligible for euthanasia even if wanted. Many of these individuals have been suffering for a prolonged time, and denying euthanasia as a realistic escape from the pains of cancer and neurological diseases like MS and Parkinson's disease could present bigger problems like mental health and behavioral concerns.
In terms of the perspective of a psychiatrist and the medical community, there may be many reasons as to why there is support for euthanasia. One of the first reasons would be the duty of a physician is to reduce and minimize pain and suffering for patients, as well as not all patients with severe mental illnesses are incompetent and have some decision-making capability. Also, there is no difference between the pain felt by a terminal patient and those with severe psychiatric disorders. So determining whether a patient should be eligible for euthanasia should not be one of physical versus mental health. Prohibiting PAD infringes on the patient's autonomy, especially if they are in mental anguish and not able to physically show their pain and desire for death. There are also many reasons as to why psychiatrists and the medical community may be against the idea of euthanasia. One of the many reasons might be that a duty of a physician is to preserve life, which is commonly thought as one of the main goals of medicine. Psychiatric disorders can inherently cause the desire to die, which would also make it seem like a patient requires euthanasia when they aren't actually in pain. thus going against one of the core principles of the MAID eligibility. Another reason may be that severe mental illnesses may cause incompetency and the inability to make their own decisions, which wouldn't allow the patient to make the decision that is best for them. As stated prior, the certainty that psychiatric treatment will not work for some patients is insufficient. This means that euthanasia, even if wanted, is not the correct course of action.
Many unexamined benefits attributed to euthanasia have been explored in the article by Riley and Sarby, where they give reasons in favor of euthanasia, even going against common beliefs. PAD and MAID would reduce private suicides, which are suicides attempted by the patient themselves at home or in a secluded setting. This is extremely dangerous for the patient, where only 8.5% of suicide attempts in the US resulted in death, and 2/3 of these suicide attempts that are unsuccessful result in hospitalization and therefore require resources to be allocated and is in general not good for the patient. This means that physician-assisted dying and MAID can naturally alleviate health spending, where not as many resources are spent on keeping a patient alive who doesn't want to be. This is important due to the fact that nearly a quarter of all medical spending is spent on keeping patients alive in their dying year. On the other hand, many think that coercion and manipulation from family members might occur, resulting in unwanted death of the patient for whatever gain. There's actually no evidence that shows that these abuses are prominent, and therefore is not a major concern in the ethical debate over euthanasia and assisted dying. Contrary to common belief, patient-physician relationships are in general not strained from differing views on medical assistance in dying and euthanasia. A study conducted in 2005 stated that only 20% of patients said they would trust their physician less if MAID was legalized. This stems from the differing views on bioethics, but most patients and people in general are not 100% set on their views in this topic. Thus, patient-physician relations would not be completely built on mistrust if euthanasia is accepted worldwide. Even in the Netherlands, public support for the MAID law is at 76%, and 74% of Americans believe that euthanasia should be legal, thus showing that euthanasia and assisted dying isn't against the public viewpoints as a moral dilemma.
As a way to wrap up our podcast, we're going to be discussing our opinion and as well as giving a conclusion to the podcast itself. So, in our opinion, we believe the legalization of euthanasia is a correct course of action to respect the autonomy and personal choices of individuals facing terminal illnesses or unbearable suffering. Although there should be a regulated framework that countries can use to provide safeguards for vulnerable and marginalized people, ensuring that ethical standards are upheld for all involved. So, in conclusion, the ethical issues surrounding euthanasia and assisted dying are intricate, often involving a careful consideration of individual autonomy, healthcare ethics, and societal principles. Ultimately, euthanasia challenges us to weigh the respect for individual autonomy with the responsibilities of caregivers and medical practitioners. While there are strong arguments both for and against the legalization of euthanasia, the question of euthanasia pushes society to continually examine how we support the dignity and choices of those facing end-of-life suffering. Thank you for joining us in this discussion, and we hope it encourages thoughtful reflection on this important issue of euthanasia and assisted dying.